Well, welcome to this episode on practice test questions, where I will break down a high-yield, multiple-choice question on appropriate versus inappropriate empiric treatments for skin and soft tissue infections in a patient with an allergy to penicillin, the kind you're likely to see on your exams. Hey guys, I'm Dr. Busti, and thanks for joining us on This Is Why, a show focused on helping healthcare professionals understanding the why behind everyday clinical decisions. Now, together we're going to walk through how to spot the key clues in the STEM, choose the best answer with confidence, and quickly eliminate common distractors by understanding why the correct option is correct and why the others are not. By the end, you won't just know what the answer is to pick, but more importantly, you're going to learn how to think through it on a test and how that same logic actually can translate into clinical practice. Okay, so here's our case and the question. A 32-year-old female presents to clinic with mild, non-purulent skin and soft tissue infection. She has a documented history of penicillin allergy, specifically to amoxicillin. This allergy was confirmed by positive skin testing in the past. Which antibiotic should be avoided? Cefazolin, Cefadroxil, doxycycline, or trimethoprim sulfamethoxazole? Now remember, guys, the goal here is to learn how to answer a practice test question, which in most cases is going to be timed. So you can't sit here debating things all day in your head, okay, about what you like or what you don't like in the question that's been given to you, okay? So the first teaching point for these is this. You have to answer the question based on what is provided. So what is the observation about this question that you may be wanting to ask yourself or should ask yourself in the real-world clinical practice environment? Yeah, correct. What type of penicillin allergy does this patient have? Of course. That would be the right thing clinically to ask or clarify and should be done. But guess what? It's not here. So don't make up information that is not present, okay? All you know is that the patient has a documented allergy that appears to be valid, which is more than most patients or what you have on hand in the real world, isn't it? Right? Now, there are a few other distractors in particular to this question that's worth taking some time to look at. The first is the setting, okay? We're in a clinic. So parenteral agents or dosage formulations are not likely great outpatient options. Well, that would eliminate cefazolin, wouldn't it? Okay, that first answer choice. So we can draw a line through that. That's probably not the best answer. The other distraction is trimethoprim sulfamethoxazole, as it is associated with known allergic reactions. We've heard of things like Stevens-Johnson's, but not in patients allergic to penicillin. Okay. So that, yeah, probably a distraction. I'm going to keep it there for now, but it's a distraction, right? Okay. I suspect there are other observations or questions brewing in some of you. For example, you might get focused in on, the detail about mild, non-purulent soft skin and soft tissue infection. Well, technically, all of the listed options here are technically things you could use. Now, out of these options, trimethoprim sulfamethoxazole is less than ideal due to its lack of good strep coverage. It's also it doesn't have an approved label indication like the other options do, okay? Now, listen, guys, that's good to recognize. But all of those can be distractions and delay time for the person who doesn't understand the STEM or the lead-in of the actual question, which is picking the antibiotic to avoid in this patient. That is the real question, and you don't technically need any of those prior tangential thoughts to answer it. Okay? This has to do with penicillin and cephalosporin cross-reactivity. That is the core concept being tested here. And as you think about Bloom's taxonomy, it fits into that analyze and apply category, okay? All right, so going back to our question, we've already kind of deemed that cefazolin is probably not the best answer because we're in clinic. Trimethoprim sulfamethoxazole is not really contraindicated. I don't need to avoid it in patients with a penicillin allergy. Okay, nothing wrong with doxycycline. That would be actually an appropriate option for this clinical scenario. So that really leaves Cefadroxil. And this is the correct answer. This is the drug that should be avoided in a patient specifically allergic to amoxicillin where we have it actually documented. So stay focused for now. This has to do with the shared or identical R1 side chains of aminopenicillin, amoxicillin, and aminocephalosporin, cefadroxil. Remember, the cross-reactivity between penicillin and a cephalosporin is greatest when they share the R1 side chains on their beta-lactam structures, and amoxicillin and cefadroxil do exactly that. None of the other answer choices do that. And while they may be used, sometimes with caution, or may not be sufficient or need some monitoring, they can still be considered in this patient. There's nothing as a result of being contraindicated. All right? Now, if you're not sure about how that works or what that looks like, I have put together a brief review on why cross reactions between those patients who are allergic to penicillin and also can sometimes react to cephalosporins. It's a rather straightforward, step-by-step guide using basic images that show you why this can happen, and even more so with certain cephalosporins compared to others. Now, if you found this information to be helpful, please subscribe to my YouTube channel. And please give us a like, maybe share it with your friends, colleagues who are also studying for exams or may want to practice applying this type of content. Our goal is to continue to produce this for you guys. Thanks for joining us and for also investing in your knowledge. I'm Dr. Busti, and I'll see you on the next practice test question. Take care.